So good afternoon. Welcome to Getting to the Blue Sky 2030, a community conversation. So what the heck does that mean? So when I joined NHF, one of my first goals was to talk to people, to find out what they wanted, where they wanted to go. And that turned into a project that we ended up calling the Blue Sky Project. So the question that I asked people was, what would you like to see this community look like in 2030, 10 years from now? We started that in 2020. If time, effort, and importantly, money was not an issue. So no constraints, what does it look like? So the first thing I learned was, if I can get the slide to change here. Change the slide. So these are the disclosures for the people on the panel. Most people have their employment disclosure. Dr. Reck has all of his research disclosures. We'll leave those up there for a second. Next slide. So this was the answer that I got. You know, this is one of the yogiisms, right? It's tough to make predictions, especially about the future, right? So that's always the challenge. But it's easy to make predictions when you're driving those directions and those predictions. And that's really what we wanted to talk about today, was how we perceive the future. So we've got panelists up here, and we've got everybody out. So as we've asked each person on our panel to give a short introduction of who they are, and then a few minutes just of what they perceive as the blue sky vision for the community in 2030 from each of their perspectives. So we're going to give Matt the first chance.
Great, Len. And would you just like an introduction or go into? Okay, great. So hello, everyone. My name is Matt Delaney. I am a community member. I have von Willebrand's disease as well as Glanzmann's thromboasthenia. I also joined NHF's public policy team just 2 months ago, but really excited to be here and talk a little bit from the consumer perspective. And I'm from Albany, New York. And thank you, Len. You put me at ease by putting a yogiism as a Yankee fan. So.
Hello, everyone. My name is Connor Graham. I am a carrier for factor 7 deficiency. I also have a clotting disorder, factor 5 Leiden, and I got involved with the bleeding disorder community about 15 years ago with my mom, Connie Montgomery. And so now I'm just kind of like making my own path, learning as much as I can as a consumer. And I was happy, and it was a pleasure to put together the ultra rare track for BDC 2022.
Welcome, everyone. My name is Maria Santaella. I am a nurse. I worked at the Hemophilia Treatment Center at the University of Miami for 17 years before joining NHF. And I work here as the director of research. I've been here for 5 years, believe it or not. And it's this whole experience have actually expanded the way I look at healthcare. And I'm excited to be part of this panel so that we can discuss it further.
Thanks, Maria. My name is Michael Rack. I'm a pediatric hematologist by training. I've worked at 3 different treatment centers now. I started at the treatment center at Phoenix Children's almost 30 years ago. Worked at Oregon Health and Science University running this treatment center there for the past 15 years. And then just this spring moved east and joined the treatment center at Yale School of Medicine. I also am the head of research, the chief science officer at ATHN, which is the American Thrombosis and Hemostasis Network, which is a nonprofit, works very closely with the NHF. We collect data for the CDC, for Health and Human Services, and also run trials.
Thank you. My name is Heather Dean. I work for Takeda Pharmaceuticals. I'm the vice president of the hematology franchise. I've been in the industry for 23 years or so, newer to the hematology space. It's been just under 2 years, but I will tell you, I'm so excited to talk about the future because there's such an incredibly rich history that I've come to understand and appreciate, and I'm really excited to talk about where things are headed in the future. Thanks for having me.
Thank you. So it's really an honor to be here. Peter Chen, I'm with Sanofi. I head up U.S. Medical for them. I've been in the bleeding disorder space, bleeding and clotting disorder space for about the past 8 years or so. So very excited to be part of this great panel and talk about some of the great initiatives that we have in partnership with NHF.
Hi, good afternoon. I'm Mary Lacey Ruther, and I head up policy and advocacy and government affairs for CSL here in North America. I will tell you, I'm probably the newest person to the community on the panel. I joined CSL in October, but I have been really impressed with the openness, warmness, the rich history of this community, and I'm so glad to be a part of it. I've been in healthcare policy for about 27 years, and I'm based in the Washington, D.C. office.
Well, that's why they had us sit together. I'm the oldest member on the panel, just flat out oldest. I started with Armor Pharmaceutical in 1977. If you remember, federally funded hemophilia treatment centers had just been funded in 1975. I think factor concentrates shipped for the first time in 1975. I worked with Armor, which today you know better as CSL Behring, until 2004. And that's when CSL Behring bought them. I was the commercial head of North America. I joined the Hemophilia Alliance, of which I'm president and CEO today, the beginning of 2006. And for those of you who don't know, the Alliance is a group purchasing organization, and our members are those federally funded hemophilia treatment centers. I'm delighted to be here today. I think the future is very bright, and I compliment all of my manufacturing colleagues in that the future is rosy.
Thanks, Joe.
So 1977 when it was a auspicious year because that's when I had my bar mitzvah. So
So you may wonder how this panel came to be. So why are we having this panel? So we have two programs for our sponsors. One is called the Red Tie Society. And if you click on that QR code, you can understand more about the Red Tie Society. But Takeda, Sanofi, and the Hemophilia Alliance are members of that Red Tie Society because of their sponsorship of the NHF. And then we also have another program called Partners in Progress. And again, that QR code will take you to more information about Partners in Progress, of which Takeda, Sanofi, the Hemophilia Alliance, and CSL Behring are members of that program. So you can get more information about those and learn more about those sponsorship opportunities of the National Hemophilia Foundation. So I believe that that's the last slide. We can go to the next one. I don't think there's another one. Yeah, so now we're going to just have some conversation. So I'm going to start with Matt. And what I want to do is have each person give a short, perception of where they think the community needs to go. And that's what we really want to hear from stakeholders. And you've got, Joe from the Alliance, and then you've got three people who represent pharmaceutical companies. And then we've got an HTC center director, a nurse, and then two subject matter experts, formerly known as patients, right? So these are subject matter experts because of their lived experience, and as you heard, with their bleeding disorders. So I'm going to turn it to Kind first.
Hello, everyone. So I think as we move to 2030 and in the next 8 years, we really need to have more discussions like this, where not necessarily we're just talking about the future, but it's everyone on the stage and everyone gets a chance at this mic, right? So it's the subject matter experts, amazing, love it. It's industry, right? It's different organizations. And so for me, I would love to continue to see everyone represented in our conferences, on our panels, in our sessions. And yeah.
Thanks so much, Connor. And we were chatting a little bit before this conversation. We were just very impressed with what you had to say. So thank you. One of the things that I really wanted to bring up here today, because I think we're at a really, really interesting time in this community. And one thing that I wanted to focus on is where we move forward 2030 with young adults and adolescents at this age, children at this age, because 2030, 8 years away, do the math from whatever age you'd like, right? But one thing that I've noticed both on the chapter level with community members that are my age or younger, that 30 and under population, is we've made so many advancements medically in these past few years, whether it be gene therapy, obviously is the elephant in the room, but also extended half-life products as well, and other products that kind of have changed so many lives for the better. I've taken Humate P since I don't know, since I was a toddler. And that involved, prophylaxis, where infusions almost every day or every other day. It became such an integral part of my life. And now with, changes in these products or with even gene therapy, there's a lot of people or young people in particular who just haven't had the same experience. And that's really good. But at the same time, I think on the chapter level that I've seen and in the community is that individuals in this age range, which will be the adults in our community by 2030, just don't have the same perspective or the same history that maybe a lot of people in this room do, or a lot of the individuals in this community do. So I think one of the things that I want to see change is how to get them involved and how to get them involved in different ways. I'm a policy nerd, so I love advocacy, access, all of those things. But we've had a lot of trouble engaging that age bracket within our chapter, our community events, because they just haven't seen what it was like before. So that's going to be really important, and I think keeping this community going, because this is a really special community, and I think once they're in it, that's your life, right? But I think the way that we can do that is increasing that conversation, increasing that historical literacy with our young people, because when I talk to young people in our chapter or outside of our chapter and go through the history, and they get to meet some of those older community members or community members that lived through various different eras, the passion is there. And the passion's going to stay there, but we need to find ways to engage them. And Connor and I were just talking before about some ways to increase equity as well. So I want to continue expanding some of those travel grants to areas where they can meet members of that community and really learn from the individuals, because we're truly standing on the shoulders of giants, but we really need to increase that that historical literacy in order to get that age group more involved, and at the same time remind them that a lot of issues still remain and they need to be there into the future, because they're the future of this community as well.
So I think both Connor and Matt brought up a really good topic that is a priority in one of our strategic imperatives at NHF, which is around health equity, diversity, and inclusion. And, one of the goals for us moving forward into that blue sky of 2030 is to be a more inclusive community. You've seen the change in the mission of NHF to be moving from bleeding disorders and earlier just hemophilia to von Willebrand disease, then to include other disorders, and now to be a little bit bolder and including blood disorders. How exactly that gets implemented, it's up to you, right? It's up to this community to decide how we implement, that mission in blood disorders and how we serve broader blood disorders community. So inclusion is an important component. Clearly, diversity is something that we need to strive for, and bringing in those diverse communities and offering opportunities for those diverse communities to feel part of a community and have their voice represented. And that's true for healthcare professionals as well. We need more diversity in our healthcare professionals. And one of the grants that we now award is the Jean Marie Lusher Award in Diversity Research. So we're looking to bring people of color into research in blood disorders by offering a research grant. So I think that health equity, diversity, and inclusion is obviously an important area. So thanks to both of you for emphasizing that. Maria?
Thanks, Len, and thanks for your ideas. So when I was a nurse in the clinic, I told you I was there for 17 years, and when you're busy seeing patients and answering phone calls, you really focus on the day-to-day situations of your patients, right? It's that micro level, that clinic that is your world, and you're trying to make the best for your patients. And it's there when I really learned to teach them to advocate for themselves. We are obviously a rare condition. Many times I receive phone calls from many providers, ER everywhere, that was like, yeah, they have a bleeding disorder. Like, what do I do? right? So not only did I need to advocate for my patients, but I also needed to teach them how to advocate for themselves, empower them with the knowledge and with the know-how and the feeling that they could do that, obviously assertively and in a very intelligent way. But they needed to make sure that I wanted to make sure they had the power to advocate for themselves. Now I've been in NHF for 5 years, and I still wear my nursing hat, and I still see my patients in the hallway, and I still, want to see their pictures. But what that has allowed me to do is to detach myself and then look at everything from the macro level, right? And that cherished, multidisciplinary, comprehensive approach that we have, it's so valuable. And so when you start seeing it from the outside, you start seeing also how fragile it is. You start seeing how we need new doctors to join our forces, new nurses. When you need that, that it takes the whole community to make sure that that HTC model that we have, whether it's through data or financial supports or being creative or, whatever it takes all of us, not just the people in the clinic, but the people outside the clinic. So advocacy organization, our chapters, our community members, our SMEs that are so incredibly smart and have accomplished so many things in the past, right? So that has allowed me to look at that model, that it's done incredible things for our patients, and look at how fragile it is, and how we have to be creative to make sure that it continues. Data is a big it's a big part of my job now. So, maybe data is the way we do it, but it's also creating new financial incentives for them to continue doing. But education, advocacy, and the sustainability as a whole. I am excited also to see that from the macro level, that I'm now starting to see what about the other rare disorders, right? What about those like he said, HEDI is a huge thing for NHF too, but it's also for everybody. Everybody's now talking about those patients that we're not accessing in the clinic. People of color, people who live in rural places, those that are really hard to find. How do we find them? Now we're really talking about them, and we're starting to find creative ways to actually go into them and finding them and bringing them in, pulling them in. So I'm very excited for what the future is. We're talking about women, we're talking about mental health, we're talking about HEDI, we're talking about, all the things that we need to start thinking about, and how do we bring that back into our HTCs that so much that could benefit from it.
I don't think I have anything else to say.
That's not true.
So-
Mike always has something to say, right?
So thank you, Maria. As a former treatment center director, I just want to second everything that you said. Putting my clinical researcher hat on, and even further back in my career when I was a basic lab researcher, that's what I would like to address, to sort of expand on what you talked about. We know that in order to make advances in this community, we have to keep asking those questions. And the one thing that I've learned working with Maria, working with the NHF, is in order to ask the right questions, those right questions aren't always the questions that are most interesting to me as the researcher, right? I thought I was asking brilliant questions at the beginning of my career, right? When Lori Wagner and I started the research program at Phoenix Children's Hospital, we were asking amazing questions, and we got some good papers and some results, but we were asking questions that we were interested in. And one of the things I would advocate for, and what I'm seeing in my own career and in other research, is getting the SME input from the very beginning. Ask the question that not only can impact the lives of the SME, their families, their communities, but ask those questions that they're asking us help figuring out, right? So take what I learned from the clinic when I talk to my patients and their families, and they ask me questions that I might not know the answer to. Use that as the lab to create the kind of questions that we should be asking as researchers. This leads to a much bigger issue, though, of course, and that's the sustainability of the research endeavor within the inherited bleeding disorders community. We're a small community, and funding for these rare conditions has to be diversified. So we talked about diversity of providers, we talked about access. We have to think about diversity of funding for research also. I love working with our industry colleagues, right? We are able to answer incredible questions together, but we have to look past industry. Washington days, incredibly important. Getting this community talking to their representatives in Congress to say, okay, well, we don't have 30 million people with heart disease in the United States, but the questions that we're asking are just as impactful for the people in this community. And then finally, to go back to what a couple people have talked about, the advances in hemophilia over the last 10 plus years have been amazing. We've got to do that for all the bleeding disorders and all the blood disorders.
He always has something to say.
So Mike and Maria have emphasized a couple really important points that came from the Blue Sky exercise. So I had talked to about 100 people in multiple different sessions, and then we did a survey, a community survey, to enhance that information. And one of the key elements that we heard over and over and over was about sustainability. Sustainability of the community. That's all of you. Sustainability of treatment centers, sustainability of hematologists. So really being able to sustain this community into the future. It was also about how we incorporate the voice of the patient, the voice of the people who live with these disorders, and also about how we use technology and how technology into the future. I think, that was heavily influenced by COVID, and people were, working from home, doing Zoom and having, Zoom doctor visits. But I think it was an important, emphasis on how we leverage technology into the future. And that isn't only around leveraging technology for gene therapy, it's leveraging technology for, digital therapeutics and digital diagnostics and all of the things that can help enhance the way of life for people who live with inheritable blood disorders. So those were three really important points that were emphasized, sustainability, leveraging technology, and then really the voice of the patient that needs to be driven. So I'd like now to turn over to our industry partners here. And why don't we give Heather and Mary the first opportunities? So Heather.
Thank you, Len. So I think when I think about the sustainability and the future, there's kind of three themes that stick out to me, and I think many of which have already been mentioned in different aspects. But certainly thinking about making sure that we're paying very close attention to those underrepresented populations. There's so much happening in this country now with an awakening and much better awareness, and I think we're not exempt from that here, to make sure that we are truly understanding how the journey from the lived patient experience to the eventual diagnosis and then the treatment and follow-up is well understood for all patients, especially those from underrepresented populations. And I think, that's inclusive of making sure that we understand real-world data from patients within underserved communities, that we are being, especially from an industry perspective, inclusive of underrepresented patients in our clinical trials. It's kind of crazy, I have to say, when we're launching a new product for the first time and we're not able to talk about data in patients that are reflective of the community in which we serve. It's a real issue, and I can speak, our company is one that has made a dedicated effort to have a group of people, a whole function dedicated on just this factor, to make sure we're looking at data from broad groups of patients to really understand kind of the full spectrum of patients that we're all serving, and making sure that we're including those patients in clinical trials. And it's not just saying that we're open to all patients in clinical trials, but it's actually understanding, why do we not have all patients included in our clinical trials, and understanding that gap, seeking to understand, and then changing the way that we actually recruit and communicate availability of our trials to patients. So that's, I mean, we could spend all week talking about that one topic, I'm sure. I think another really hot topic that I feel like we're hearing so much about is women in this space. And it's not just carriers, right? It's women who may have mild disease. It's women, you know, parents and caregivers, of course, but there's so many different things. I was just in a bunch of conversations this morning with women who talked about the fact that they have a rare blood disorder, and it took 16 to 18 years for them to just figure out what it was and then to try to nail down treatment. And it's an absolute shame. But I think what's great is there is so much more awareness that's, I feel, growing at the moment about acknowledging this really important group of patients, women who are impacted by rare blood disorders in many different ways. So I think together to continue to seek to understand more and better serve that community. And then the third area, of course, I would say this from an industry perspective, but it's so important for patients that they continue to have access to care. And, having worked in many different therapeutic areas, certainly in a broad primary care environment, we know historically that payers were very efficient at effectively managing some spaces. And I think we're starting to see that kind of creep into rare disease, unfortunately, where, gosh, there are such unique and nuanced and specific needs that patients have. There's a very specific reason that a patient would need a particular therapy. And it's incumbent upon all of us to ensure that patients have access to those therapies. So I think that's something together we are all working really hard to advocate for the benefit of patients. So kind
Thanks, Heather.
of three high level.
Mary?
Thank you. And I would build off of that, Heather, because when I think about 2030 and what the environment looks like, I think, the healthcare financing environment just generally gets a little tougher. And when that happens, like you said, I think rare disease has been inoculated from that up until probably now going forward. And I would just commend this community because since I've been here, I have been really impressed over all the great work that you've done in the many years to make sure that your community has the resources that it needs to have, and that you've worked with the governmental entities at the state and federal level to be able to ensure that. I think part of what you need to, and when I sit back and think about the environment too, I think about there's a lot of people in this space. There's a lot of voices in this space, policymakers especially. It's really hard to continue to break through and have messages come in and have the real connection with them. So, Matt, building off of what you said, about the community, you guys have been just such advocates. I think just continuing to do that, and really making sure your voices are being heard, not sitting back on that at all. Doing more, I think is going to be really important as we go forward, because these spaces are very crowded when you start going in and talking to people, and being able to have that is just really, really important. So, I mean, to me, the other big component, and I know this community does this already, so I feel, I'm preaching to the choir here, is really collaborating with a broader cross section of other, organizations. Been very impressed with the leadership that so many people have been exemplifying, especially at the state level, running a lot of the copay, accumulator type of bills that are there, working with and leading such a broad cross section of other patient organizations. And that, again, that type of collaborative work, especially where you can find issues where you can be really aligned, and kind of thinking about the future of what payment policies should look like. And I know that's a big conversation that the community is having, is the sustainability of the model. What does that look like going forward? I think part of that is really going to be the collaboration with other communities who are facing the similar type of challenges in that space. When one of those communities that comes to mind is really the oncology community. So that's just some food for thought, and kind of thinking about like the future.
Yeah. Why don't we let Peter go?
Peter, sorry.
Oh. Thanks, Lena. So great stuff. There's a couple of things that hit me first of all, that 2030 is only 8 years away when you said that. And I was thinking when I joined the panel, it was like 40 years away. So time flies. We'll all be holograms next time we talk here. The other thing that resonates with me at this meeting is Len's vision and the NHF vision about expansion beyond hemophilia. And that really fits Sanofi's portfolio, right? Across rare blood. So I lead the team. Our franchise is called Rare Blood Disorders, right? With clotting and bleeding disorders. And what that means is not, oh gosh, our portfolio matches great, right? We only have to work with one partner, but rather the power of NHF brought to less underserved populations. Because seeing those populations, we brought together those patient groups today, it wouldn't fill this room, right? And NHF's power and the learnings from that community really can power the other groups. So we're really excited about that. I think that it's great synergy and vision there. The other portion is the patient voices. We totally agree with the subject matter expertise. And what I hope patients realize is how much they actually can influence clinical design, clinical trial design, and therapies, right? One thing that strikes me is I saw a patient survey on hemophilia B one time, and these patients, despite good bleed management, there's still this strong dissatisfaction and unmet need with their disease state, right? So we look at these charts on the wall about, our clinical outcomes, and it was focused on ABRs, joint bleeds. But we know you can achieve 0 ABR by sitting still all day, right? So what does that mean in terms of your outcomes, your goals, things like that? And I think if you look at the therapies that we're trying to bring to market and in partnership with other groups as well, right? It's not just Sanofi, is that we're looking beyond those things. We're trying to bring patients to as near normal life as possible. And that should be the goal. And that would not have been the case if it wasn't for the patient voice. And so we're super excited about this, understanding how we can move beyond clinical endpoints or even incorporate the patient voice into the clinical endpoints. So these are the key priorities of ours. And I think there's great synergies here and opportunities for partnership.
So I mentioned earlier that the federally funded hemophilia treatment centers came into existence in 1975, and they came into existence at the request of the patient community, or maybe the demand of the patient community. So it's a community where listening to the patient has occurred for a long period of time. And I think if you reflect back on the last almost 50 years now, the federally funded HTCs have really been the cause of all the innovation that we've seen over these last 50 years. Yes, all of the industry invested in it, but imagine trying to accrue enough patients to power these clinical trials. You couldn't even find the patients. You wouldn't have the clinical staff to run the clinical trials. And I think we're at a critical point in time where we have to not take the existence of the HTCs for granted. All of these advancements are wonderful. They're going to benefit all patients in the community, but only if we can sustain the HTC network, because what we found is that having great products is great, but you need great clinical care to go with it. So from our perspective, we're talking to manufacturers now about bringing gene therapy to market exclusively through the federally funded hemophilia treatment centers. And I think there's a lot of great reasons to do that. First and foremost, it's the best way to assure the best possible outcomes for patients who take gene therapy. So, Matt, if you get excited about something, I think you should get excited about sustaining the HTC network, because it's really the core of what's made all of this progress possible.
So that was sort of the,
You can just turn on, maybe.
I don't know how to turn it on. Is it on?
Is it on?
It's on. Can you hear me now? Okay. So, we wanted to give our panelists an opportunity to provide their perspective, but we've got a few minutes for a community conversation, for other people to provide their input or their comments on where 2030 could go, or ask our panelists a question. So maybe I'll ask our panelists, do you have any questions of the community or of each other? Dr. Reck, you have the microphone.
I do. And a voice. So I guess the first question I'd like to ask for people that are attending today would be, what would you personally view
Microphone.
as being cured of your disease? What does cure mean to you?
Over there. Lynn.
So the question
Oh,
was,
that's gonna-
what does it mean to be cured? What is your definition of being cured? Oh, how about an answer to that one?
What do you say?
Is that what your question was, Mike?
Yeah.
I was worried about killing myself jumping off the stage.
What does it mean to be cured?
What does it mean to be cured? Anybody want to take that? Come on, somebody's got to have an answer.
Hi, Lori. Lori and I worked together for 10 years at Phoenix Children's Hospital, and the beginning of that answer does not surprise me one bit.
I'm going to answer for my son is what I'm saying, which I should learn not to do, but he's not here, so I get to. To me, for my son to be cured would be a therapy that he takes one time. It works with no side effects, and he never has to worry about it again.
I love your dress.
I know that's a big mic drop, but ultimately, to me, that's what a cure means. Now, there's probably iterations along the way, but that would be the dream.
What about passing it on to future generations? Where does that fit?
So that's a great question, one that I probably selfishly haven't thought a lot about, because you get so caught up in your little sphere. But yeah, I think if you could add that in there to the wish list, sure, the gene doesn't get passed on.
Thanks, Lori. So I see one of our expert clinicians in the audience here that I'm going to put on the spot here and ask Dr. Guy Young, who's never also at a loss for words, to reflect on his perception of what does cure mean.
Well, since you put me on the spot, actually, I was thinking about that for a moment, and I wasn't going to share this, but I'll share something that is personal and not hemophilia related. I don't have hemophilia or anybody in my family with hemophilia, but I did have cancer 15 years ago, 13 years ago. And cure for me meant, when my doctor said, we can cure you, I said, well, that means I won't even be thinking about this anymore. And actually, I got to that point, and I don't even think about it. Only came up now. It popped into my head about when you use the word cure. So I think what it means, and if I can translate that to hemophilia, it's really not thinking about the disease anymore. I mean, the issue of passing it to offspring, I mean, we're very, very far away from something like that. And there's a lot of ethical issues with gene editing our own, our eggs and sperm. I mean, there's, that is, we don't, I mean, ethically, that's a very charged issue. So I think that part is probably going to remain. I don't see how that's going to go away. But if we can cure patients from an early age, then that's probably not even that big a deal. And so to me, cure is getting a treatment to patients early enough in life before the manifestations of the disease happen and before any chronic conditions happen from it. And so I'll close by saying that for me, an irony of gene therapy is that it's only being studied in adults who already have, in many cases, established joint disease, and that we really should be thinking about how can we bring this treatment to a 1-year-old before they ever had a bleed. And I realize there's a lot of issues and ethics involved with that. How do you consent somebody for something that is potentially lifelong when they're a child, when maybe if they were old enough, they wouldn't want it? So there's a lot of things like that, but cure means you don't have to think about your disease, and you can just go on with your life. That's how I view it.
Thank you, Dr. Young. So my new friend over here, Dan, has a comment or a question. So we're going to go there, and then we're going to go to the front of the room.
Thank you. I personally think cure at this point is a pipe dream. And that when you speak cure, it's more than just physical, it's psychological. it's social. I mean, all of us old guys, we have a lot invested in hemophilia. Our bodies have a lot invested in hemophilia. So it's more than just curing the hemophilia. You got to cure up here also. And that's, after 58 years, that's going to take a lot to do. So if it was just a physical cure, we can hand out liver transplants like they're candy, at least for hemophilia. So, but it goes much deeper.
So one of the areas that NHF has taken up, primarily because of maybe the pandemic, but maybe, you know, the same reckoning that we've had for other reasons, mental health. And mental health is one of our priority focus areas to learn how we as an organization need to interact better with the community, to do more to support the community, as well as to train our healthcare professionals to do more and interact better with their patients. So mental health is a huge issue.
Well, hello. I am going to say something out of the US. I'm from Argentina. I'm coordinating a continental organization, the coalition, and I really, I can't believe the effort and the organization that the NHF is going on, the chapters, the national nets, the relation with the HTCs, and maybe the idea of cure depends on where you are living. It depends in the US, in UK, in Africa, in Argentina, or in Asia. But I think that I want to have a pill to drink in a few years, but I know that it's not going to be like that in a few years. But I really think that to be in community, to have relations, to be in this moment with all, having sharing experiences, talking about which is 2030, which is the future, where are we going, gene therapy. I don't think that it's the cure, but it's a lot of steps that collaborate with us in thinking that not for me, for my child and the future generations are going to have a better treatment. When I was, well, I don't want to say how old I am. I am 41, but at my 15,
Younger than Joe.
yeah,
Younger
yeah,
than
of
Joe.
course, yeah, of course,
We're
literally,
all
of course.
younger than Joe.
But when I was 15, 12 in Argentina, treatment, I had treatment on demand, and that was a pity because today I have some arthropathies. But now we have prophylaxis, and we want to have prophylaxis in all the countries, in the developed countries, and those countries that they are starting to be developed. And that is the future too, because those guys, those kids, they are not going to have the same problems that today I have, because prophylaxis is the main and the heart and the central parts of all this situation. Adding psychosocial, adding social services, adding healthcare systems, adding the community. But it's important to know that the future will be better than the past. And I think that is maybe not the cure, but it's a light that we have in front of us.
Thanks, Antonio.
Lenny, can I just address something first?
Sure.
I think you're spot on, right? Because in the US, there's a lot of unmet needs still, but we're lucky in a way, right, across the board with medical care. And to your point, a cure, gene therapy, while promising early stages, but promising, the infrastructure probably isn't in place to do that in third world countries, right? Especially the amount of follow-up care and things like that. So I think just as a company, we are completely aware of that. And while we look at market opportunities and things like that, we're also investing in things that would surpass logistics, right? No refrigeration, reduce, different routes of administration, and not to say, hey, we're going to bombard the U.S. market, or it's more to focus on healthcare quality across the board, understanding that some countries may not have refrigerators. So what therapies can we bring into the market to that extent, right? So it's a great point, and definitely something that we're looking to focus on.
I think it actually raises the point, though, that Dr. Young made. which was, we're developing gene therapy for people, for adults, right? Where maybe the children are the ones who need it most. You make the point and the argument that maybe we should be developing gene therapy for places where gene therapy is needed a lot more than in the United States, which is in the developing world, where access to care isn't as good. Granted, we don't have refrigeration, but you can't refrigerate. If you don't have a refrigerator, you can't refrigerate factor concentrate either. So you're sort of in this bind, and I think we as a community need to think about where do the resources really get positioned and be most utilized and most valuable. Antonio, you had another comment?
No, I think really that the future is in our hands. We must push the government, we must push the decision makers, we must change the ideas or the cultural ideas that, we must see today the cost. Well, this is cheaper, well, go with this treatment and not for the other. We must try to break that bubble that maybe sometimes in Caribbean, Latin America, the countries, the decision makers are involved only in that bubble. We must break that, not only for us, for the states too, because they are going to pay cheaper and have a better treatment and quality of life of the patients, to the industry, to have new markets, to all. I think that it's a win-win circle, but we must push that. And I really appreciate the volunteer work of all the leaders, of all the staff, of all the organizations to do that. That is the main important part that we can do as patients, as a community, to go ahead with a better treatment in the future.
Thank you. You know that as we sit here and we think about the United States, and of course we're looking at our challenges, we're looking for opportunities, we're looking for, for trying to envision the world in 2013. One of my other favorite things about working with NHF is that I've really gotten to learn very closely the work of WFH, and Dawn in particular, who's sitting there, the incredible energy and all the learnings and everything that we try to share, because we are conscious that our community here has many privileges that we don't have it, and you're bringing it perfectly to light, right? The work that this organization is doing and the work that we can do as a community, and I'm singling out NHF because I'm familiar for the work that we're doing and how we collaborate and try to make, we're always thinking about, the other countries in the world that are less privileged. But I invite you as a community to really think about that and think about how we can all together accomplish incredible things. So volunteer work, sharing learnings. I mean, there's a limit amount of work that we can do, but every little bit of it counts. So I thank you for bringing that perspective, because as a Latin American person, I hear you.
So, I think we talked at the beginning, and Matt brought it up, and Henry talked about it a little bit, was the health equity issue. And, one of the big equitable issues is women. And we have in our audience here the chair of the WFH Women's Committee, Dawn Rodolini. And Dawn, so maybe what's your perspective for, women into 2030 and beyond? How do we achieve the goals of equity for women with blood disorders?
Well, that's a simple answer, Len. No, but I have given this a lot of thought. And in our committee, I'm one of a committee, and we have incredible women from all over the world on that committee. And I'm thinking of their voices and what they would say. The first thing that they have to do is get through the barrier of women don't bleed. We've got to get through the barrier of, oh, honey, don't worry about it. That's just what you have in your family. And this is not a big deal for you because it's just a period. Or we have to get through the taboos of the conversation of even being able to talk about heavy menstrual bleeding. And that's also in our own country. And so I think there are a lot of steps. I think there are a lot of barriers. But if you want to talk about a cure, I will go back to the comment that was made about, and I know you were speaking for your son, but I think it is where at the age of 1 or whatever age, you are given a treatment that means you don't pass it along anymore, but that it could be for women and girls. It could be for ultra rare diseases. It is a cure for anyone with a bleeding or blood disorder, means it's done. it's stopped, that we can fix it in that first year so that you don't have to worry about the fact that no one will take your bleeding seriously. No one will even ask you the question when you bring your child into clinic, are you having bleeding issues? What's abnormal bleeding for you? And so I think those are the questions that don't get asked. But if we really are talking about a cure, we're talking about the fact that those questions don't even need to be asked.
Thanks, Dawn. And if you don't know, the vision statement for NHF is a world without inheritable blood disorders. So that means it's a world which is global sense, geographic, but it's also the world of bleeding and blood disorders, and we're focused on cures.
So we have an online, Ashley Gregory she said access to diagnosis, treatment, and medication is the first step. She agrees. She wanted to thank Lynn, Dawn, and the NHF team for helping women with bleeding disorders. We also have another from Connie Montgomery online. She stated that in 2030, I would like to see a refreshed and rebranded NHF, HTCs and chapters ready to embrace the needs of the diverse, multi-generational, and broad population they will be serving in this nation. The 2022 Bleeding Disorder Conference is on target, planning and looking forward for this bleeding disorders community. We must partner with many systems, organizations, and businesses to help us navigate a future that includes every area of intersectionality for all people. Cures, services, and removing barriers starts with these conversations and move forward to actionable steps. The future is the result of what we do now. Thank you, Connie, and thank you, Ashley. We have Thank you.
So I know that Dawn mentioned very briefly ultra rare bleeding disorders. So along those lines and along the lines of what other people have been saying, I feel like a cure for all is really what a cure means. So I know that it's a little disheartening for some ultra rares when the fact that every single treatment for every single ultra rare bleeding disorder can be condensed down into a 1-hour meeting. So it's definitely, I feel like a cure for hemophilia is super exciting and it's super incredible, but it also makes me feel a little bit bitter because I know that factor 10, factor 2, factor 5, factor 11, factor 13, factor 7, Glanzmann's, they tend to get left in the dust in a little bit. And so it's 2030 to me looks like the treatments we have available for hemophilia A and B, the beginnings of gene therapy for my bleeding disorder, because 2030 to me is just being able to attend these conferences and see these treatments for hemophilia A and B and think to myself, hey, I have an alternative like that too. I have more than one product. I have one product. Some of us don't have any. And so it's 2030 to me is a cure for everyone, a treatment for everyone in all places of all ages. And that fits everybody's needs, no matter what your disorder is.
Yeah, thanks. Thanks for your comment, because I think that's a really important point. And as I mentioned before, when Dan made his comment about mental health, and I mentioned that that was one of our priority focus areas, rare and ultra rare bleeding disorders is another one of those 5 priority focus areas. So we're putting special emphasis to try to understand exactly how we move forward to get to the same place in 2030 with ultra rare bleeding disorders as we are with hemophilia A and B today. So we have another question, Lawrence?
Yeah, thanks, Len. Hi. I just wanted to make a comment actually following from the online, just talking about obviously how the organizations reflect the diverse kind of cross-section of the community. I think I would argue, and particularly over in Europe, there is chronic disengagement. And even through some of the research that I've engaged with at a US level, I'd also challenge the US community to say there is chronic disengagement. So we can keep creating as many resources as we like, but actually, where's the audience? You need to build the audience first and then drive value. So I would challenge, particularly around the research side, the research is undermined if you haven't got that, cross-sector of the community actually informing that. So I think, again, I would challenge the advocacy groups, not just in the US, but actually globally, because it is a global issue, about how do they create sort of brand equity. I think, I love Nike. I have loads of Apple products. They sell me an idea. They sell me a lifestyle. I think the organizations have to some way think about how do we create brand equity whereby people are buying into what we do and the services and the delivery of education. Yeah. And so I would really challenge the community to think, I think we really got to think innovatively about this, because as I say, all I'm seeing is the sponsorship and funding of resource delivery and tactics that ultimately fall on deaf ears because nobody is engaging with them.
Well, Lawrence, you just volunteered for a new committee, I think.
I'd like to add what he said. Ashley came in a little earlier. She's just created, along with Ray Dottoli, a women's equality with bleeding disorders thing. I know Dawn Rodolini is on their advisory committee, Dr. Sidonio. Several of us are working various issues. Since 1972, we've had resources that tell us that women do bleed. There are numerous studies that have said this, and little bit is happening. To make it happen, I think what Ashley and Ray are doing, they're bringing all of the different entities together in an ad hoc committee to address this. This is important. And then, as Lawrence over here says, we need somebody to put that together in a coherent message. We begin advocacy now because it will take several years to make the case. We need to get on this. We're starting to. Let's do it.
Thank you. So we've got a couple minutes left, and I want to we always try to give the first word to a patient, and I'm going to give the last words to a patient. So Connor and then Matt.
Yeah, so thank you all for your comments and your questions. Thank you for the shout out to ultra rares, because that's what we're here to do, right? Create a space for everyone with a bleeding disorder or blood disorder. And so as I was sitting here and I was thinking of something amazing to say, like my mom just said in the comments, wow, thanks, Mom. I love you. I said this at a session yesterday, but for the community, the subject matter experts, to continue to say, hi, I'm here, this is what I need. And then on the other hand, it's our responsibility to be like, okay, we hear you. We hear that you're here. And this is how we can provide those needs. So.
Last word, Matt.
Hard to follow you up, Connor. Wow. No, and echoing everything you said, and I think the quantity of questions here and points really show that, and especially the shout out to the ultra rare disorders, which we'll actually be talking about very briefly or very soon. Yeah, and then also talking about the audience and how we engage that audience. But I think we really had a lot of discussion around we're going to a really, really exciting place, but we also can't forget the foundations, right? The 340Bs, the mental health piece, the diversity, equity, inclusion. So I think we're really entering a new era and a really exciting time, but we need to remember also where we are and how we back that up at the foundation. So I really appreciate everyone's work in doing that, everyone on this panel and everyone who asked questions and brought up really good points today, because the future is really bright, but we really have to make sure we work at it and not leave anyone behind. So
Again, I'd like to thank our sponsors, Takeda, Sanofi, CSL Behring, and the Hemophilia Alliance for the support that they provided. The QR code is here to submit your evaluation. Please scan the QR code or go in the app and do it. But we desperately need your feedback so that we can continue to improve our programs for BDC 2023. And when you come back next year, there will be a rebrand, right? You heard last night, we're going to have a rebranding of the organization to better reflect the diverse communities that we represent. So thank you all for being here. Enjoy the rest of BDC. Thank you.